Very common in Chad's case is that Chad literally came to me saying, I just want to do something with my smile.
Yeah, right. My front 4 teeth were chipped, and
right.
I was self-conscious about it.
Right, and so that was what precipitated the whole conversation about doing something. And whenever I see an issue like that, typically form follows function. So if the teeth don't look good, then there's something usually functionally wrong with the way the teeth are working together. So in neuromuscular dentistry, what it teaches us is to take a step further back. Don't just look at the way 2 teeth fit together, but look at the way the teeth fitting together maybe affects the patient. So I think that steered us towards, once I saw his teeth, knowing what I know, me asking him questions that he started responding positively to as far as symptoms that he might be suffering from, the cause of the way the teeth looked, and then what the solutions would be to get him back to the point where A, he had the smile that he wanted, but maybe also B, we can regain some of the functionality of the body that maybe he had lost over time due to his bite position. And so I think that's why that conversation went that way, and that's pretty common actually. Usually people don't show up knowing what neuromuscular dentistry is or what it can do for them. Most of the times when you go to see a dentist, it's just about, this tooth is messed up, please fix this tooth. Neuromuscular dentistry isn't just about looking at one tooth and the way 2 teeth maybe fit together, but looking at the way all the teeth fit together affect the patient, because orthopedically, if your bite's off, typically your head position is going to be off. And if your head position's off, then patients start to suffer from a myriad of different symptoms. We used to always commonly call these kind of syndromes TMJ, and that's pretty much what everybody knows it by. But the reality is TMJ is just your joint. It's your temporomandibular joint. So we've created a bigger bucket to put a bunch of different symptoms in, and now we call it TMD, which is temporomandibular disorder. And within that bucket now goes joint problems, TMJ issues, also muscular problems. Chad had, what kind of symptoms did you have? Neck aches? What kind of problems?
I had a lot of stiffness in my neck, and you pointed out something to me that I didn't even realize about myself, and that I was sitting and my neck was moved forward and my chin was up.
Right.
And that's something that, since we've gone through the process, that I feel I've eliminated, and I feel kind of like I have the posture I had when I was a kid.
Yeah, and he hits on a key point there. What he's talking about is head position. And typically when we start seeing front teeth worn down, we're wearing our teeth down, so we're having to close our jaw more and more and more all the time to bring our teeth together. There's a little hole in the back of our throat called an airway, which we breathe through. And if that airway gets pinched off and becomes smaller, we tend to, because we're smart enough, to start moving our head forward to keep that airway open so that we can breathe the way that we need to. So a very common posture that we see in patients that have overclosed bites is forward shoulders, forward head, and usually tip to the side a little bit. And it does create issues with range of motion, ability to turn your head. And then patients tend to start suffering with muscular neck issues, which to them can be just a chronic ache in the neck. It can be headaches in the temporal area. It can be masseter soreness. So those are the muscular myositis things that we pick up. It can even disseminate all the way down to the lower back, because if the head's not sitting right on top of the spine, it gets out here. The head weighs 8 to 10 pounds. If it's sitting on top of the spine, then the body can deal with it, and positionally it's easy to hold it in place. But the further forward it goes and off of that alignment, then the muscles all the way down the back, even down to your lower back, have to start straining to hold the head back. So as your head goes forward, you activate muscles in your back to support poor head posture, and then chronic use of those and then never being able to rest leads to the kind of pains that people can have. So those are the myositis kind of things. And then the third thing that goes into the TMD bucket is neurologic problems, meaning if you have a forward head posture, the spinal cord that goes down the center of our vertebral column, there are little branches that come out and they exit through the foramina in between the vertebrae. And if your head's pitched forward too much and the neck curves too much, it begins to compress those nerves, and you can start having paresthesia issues. Sometimes you get numbness in the arms, tingling in the fingers, and it can also disseminate all the way down to your SI joint. I've had patients that have had sciatica problem due to compression of the nerves. So TMD is the new term that we use. It includes joint problems, muscular myositis issues, and then also nerve problems that you can have. So all those things can be related, believe it or not, to a bad bite. There are other things that can cause it. For example, people with leg length discrepancies can have a tilted pelvis, and they can have sciatica pain. But Chad didn't have sciatica, but I have other patients that do, and if their head position's off and the spine twists and torques to support that poor head posture, then you get compression of nerves. So resetting and giving the patient a more ideal bite, as he said, gets him back to the posture and the way he was when he was a kid.
Yeah.
Nobody typically comes out misaligned unless you've got a real problem orthopedically with the way your body developed. We usually start out pretty aligned, and then as our teeth start to come in, we start to diverge away from that optimal alignment. But because we're kind of hardwired, we've got the same nerves and muscles and joints and bones that we had when we were born, and we're going to leave with them. But in the middle, we get teeth, or maybe we get orthodontics, or maybe we get some dentistry, or we get some teeth pulled. Because the jaw can move sideways, up and down, forward and backwards, and then all the things an airplane can do, pitch, forward and backward, yaw, swing side to side, and roll up, right and left, we're able to get our teeth together. Doesn't mean it's ideal, so you go from being an optimally aligned ideal baby to a misaligned adult, but because we can hit the reset button using neuromuscular dentistry, we can talk directly to the nerves that regulate lower jaw position, which facilitates head posture. So it's like turning your computer off when it slows down and restarting it. We can do the same thing with a TENS unit and reset the patient back to alignment so they can be over here and we can get them back to more ideal functional alignment, stabilize the bite there, whether it be with dentistry, orthodontics, or some other version of that, and then let the patient live at that more aligned position. Just enhances the life. And I think that's what you've kind of noticed, is that it was more about just teeth and a pretty smile.
Absolutely, and that was a process that you introduced me to, and then you realize it as the patient, during the process. I mean, it's small steps. It's not like a magic wand. So I knew what he was saying to me, and he had explained this to me. But that's where the faith comes in, and the idea that this is a process, and that you're going to have to go through this process, and gradually over time things will come and correct themselves. And then it's very striking. There's a photograph that he has that I have too, and I've kept it. And it's the before, and then it's the after when I finally got I just think they were just the temporaries.
It was your temporaries.
But they were the same teeth, just not the final material that I was going to leave with. And the difference from my shoulder, the squareness and the symmetry from my shoulders to my neck and my posture, it was, to me, it was striking. Mm-hmm. And that was something that I would certainly use that.
Oh yeah.
with people that come in, but it was something that it exceeded my expectation, because like I told him previously before you came in, I was more thinking that it was going to be a fix my teeth type situation, and I didn't realize that it would be more of a holistic or an overall correction.
Right.
And there's hills and valleys through that, and that's something I want to communicate to the next, or anybody who's looking at this. But the final result can be much more than just having 3 or 4 teeth fixed. Obviously, it's much. There's an entire alignment issue, or there's an entire comfort level that you can achieve as well by just having a healthy bite. And who would have known that? I, as a layperson coming into it and not ever having been exposed to that until I met you, I had no concept of that. And when you introduced me to the concept, it almost seemed too good to be true, almost. But I went with it, and the result is fantastic. And that's why I'm doing this video. This is something that I do so that other people can realize that it's not, a fairy tale. It's reality, and it's something that can be very tangible, and it's good for its quality of life.
It is, and I think one thing that I want the listener at home to take home from this is that you might be searching for the silver bullet to the cure for whatever might ail you. Neuromuscular dentistry is more of a holistic technique, as Chad said. We never used any pain pills on you. We didn't give you Botox injections. Sometimes we use physical therapists to help, reset the body and loosen it up to get it to function better again. But it isn't about taking meds. It's about letting the body heal itself. There's a class of patient that I quite often see that we call the wanderer. And they've seen ENTs, they've seen chiropractors, they've seen acupuncturists, they've had their eyes looked at, they've gone to headache clinics, they've done sleep studies, and they can't seem to get beyond the level of care that gives them, sleeping pills at night, muscle relaxers, and pain pills. This doesn't fit for every patient, but there is a class of patient out there that is wandering and looking for an answer, and neuromuscular dentistry quite often sometimes has that solution. It's something that we don't just pull a trigger and give Chad a bunch of crowns. This is a process that takes a period of time. The first thing we want to do is, number one, take a look and see, is the bite possibly leading to the patient's problems? And I have a system that I go through to help me decide that. That's step one. And then explain that and show the patient what I see. Step two is going to be, if it does look like it's a bite problem, then we need to give the patient a new bite. And the way that we do that is with a removable appliance called an orthotic. We call it an orthotic because it's just like a leg length issue. If you've got hips that are out of balance, we want to lift the foot a little bit with an orthotic that you insert in a shoe. We're going to do the same thing, but we're going to use an appliance that goes in the mouth, fits on the lower teeth. It's clear acrylic. Chad lived with it for 6 to 9 months, and that's about how long our bite test drive period is. Because we want to decide, is it or is it not the bite? And the only way to decide that is to give the patient a new bite. This is completely reversible. If it isn't working for the patient, we just take it out and the patient goes immediately back to the bite that they had when they walked in. So we do no irreversible dentistry. We use a removable appliance, test drive the bite for at least a period of 6 to 9 months, make sure that that's what's ailing the patient, and then eventually convert the patient from a removable appliance to something like Chad's got, or sometimes if we're able to, we'll send a patient to an orthodontist and have the teeth moved to a particular endpoint. But that's the process. So it's essentially 2 phases. Phase 1, test drive the theory of, is the bite the problem? By using the removable orthotic. We do have a fixed option for those patients that don't want to use a removable appliance. I prefer the removable, but there are some people that can't tolerate it, so we do have another way of doing it. And then phase 2 is taking the orthotic away and converting the patient to a bite that holds that ideal orthopedic lower jaw, upper jaw alignment, and that facilitates head position reset, increased mobility, flexibility, neural recruitment of motor muscles, and then also just let the patient live in a better position.